there's all sorts of interesting diseases out there. Elephant man syndrome, progeria, which is where you basically die of old age at 10 years old. All these really interesting diseases, but probably the worst one that's out there is depression. And that's what we're going to talk about today, mood disorders. So there's nothing like depression. It's probably the worst disease, in my opinion, and I'll make an argument for it, that it's the worst disease that you can possibly have. It's absolutely crippling. It's incredibly pervasive. Up to 15% of people have it during their lifetime, and that's worldwide. So it's the number 4 cause of disability on the planet. That's the entire world. And by 2025, it's expected to be the second cause of disability on the entire planet after obesity and diabetes-related disorders. So it is really bad news, and it's becoming more and more common. I'm going to talk about, in this lecture, the multidimensionality of depression. You have to understand each area of depression in order to understand it. And the areas are biology and psychology. So what does biology have to do with depression? What does psychology have to do with it is what we're going to be mainly talking about. But to start with, first of all, we have a semantic problem. So depression is something that we use every day, like, oh, I'm so depressed, and oh, my favorite show got canceled, I'm so depressed. It's not really depression. It's sort of an everyday mild grief that we deal with. We get through it, it's done with, over with, and we move on. But there's bigger types of depression. So there's also depression where there's a big event and you feel terrible. Or there's an even bigger type of depression where individuals don't really come out at the end. This just becomes a continuous depression even after that original event is finished. So you've got the everyday depression, you get bad news, you feel bad for a few days, you're better. The second type is reactive depression. Somebody dies, unemployment, there's something going wrong that causes extreme impairment for a short period of time. And then major depression is where there is a large loss, but the big difference is that a long period of time goes by, weeks, maybe months, and you still haven't come out the other end. And after a while, the thing with major depression is it doesn't really take anything major to trigger major depression. It sort of becomes a body habit, a mental habit that the brain develops. And I'm not saying the person does it on purpose, but it becomes, and maybe habit's the wrong word, but it becomes this chronic thing that doesn't even take a major issue after a while to begin to trigger. So to define it in one sentence, major depression is a biochemical imbalance, biochemical disorder with a genetic component, and early life experiences where basically somebody can't appreciate sunsets. You lose pressure. You lose pleasure in your life. And this is a really sad thing. I mean, other diseases, and this is why I say depression is the worst thing that could happen. You know, you hear about people getting cancer, and they talk about how, oh, it's the best thing that happened to me. I realized the value of my family and friends, and I quit this horrible job that I had, and it changed my life. And so in a sense, it was this wonderful thing that happened. And depression isn't like that. You don't have pleasure during depression. You don't have that growth and changing and reaching out to the people around you. And so that makes it really miserable. Okay, sorry, I had to escape the wind. It picked up in 5 minutes. It went from no wind at all to so much wind that you probably are having a hard time hearing me, or were having a hard time hearing me. All right, anyway, so those are the 3 types of depression: everyday, reactive depression, and then major depression. And the difference is really in the intensity of feelings as well as the length of time that you're experiencing it. And we're going to mostly talk about major depression in this lecture. So what are some of the symptoms of major depression? The number 1 symptom is anhedonia, or lack of pleasure. And that's really what makes depression so horrible, is that you don't experience any enjoyment of life, or very little. Your enjoyment of life is blunted. You also have grief, a feeling of loss, and it's not necessarily grief over somebody dying, but grief can be over anything where you feel like you're you're losing out on life, that things aren't going right. And it doesn't necessarily have to be a reason for it. You just have a feeling of grief that's there regardless of the rationality of it. And it can be so severe that it takes on a delusional quality. Like you're sure everything's going to go wrong and everybody hates you, and you have these severe negative feelings that there's no rationality for. And it can literally become delusional too, like seeing things and hearing things that aren't there. That can be a part of depression. So if somebody's hallucinating, doesn't necessarily mean they're crazy or they have something severe like schizophrenia. It could be that they're just really depressed. You also have a sense of guilt, of doing things wrong, beating yourself up. That's those cognitive, the things we say to ourselves in our head is a big part of depression. One of the other unfortunate parts of depression is self-injury. So self-mutilation, suicide, unfortunately. Suicide is actually the leading cause of death for teenagers, which is horrendous, but true. Now, another big part of depression is something called psychomotor retardation. And this means that you slow down. You're too exhausted to do things. You're too exhausted to think. You know, your boss sends you an email and you can't handle writing out 2 sentences to send back to them. It's just too much work to do. Or Lord forbid you have to take a shower or brush your teeth or do your laundry. It's too exhausting to do. And so a lot of people with depression will think that they're lazy, and people around them will think that they're lazy. And it tends to be chalked up to personality rather than to an actual physiological cause. Now, one of the interesting things about psychomotor retardation is that if somebody's on suicide watch, you don't put the really severely depressed person on suicide watch, because when they have psychomotor retardation, they don't have the energy to like, oh, I'm going to cut up a bunch of sheets and make a noose to hang myself. That's way too much work when you are severely depressed. But it's actually when people are getting better that they're more likely to commit suicide, and that's when you have to watch them, because it takes energy and effort to commit suicide. So if I feel a little bit better, my psychomotor retardation has decreased, I have a bit more energy, and now I actually might commit suicide. This may be part of the reason why when people start antidepressants, it increases the chance of suicide, because they actually feel a little bit better. But they still feel crappy and horrible about their life, but they have enough energy and motivation to do something about it. You also get vegetative symptoms. So like we all feel depressed, we all feel lousy, withdrawn, we feel grief, but then we get better. So one of the things with depression is, since we all deal with these sort of vegetative symptoms to a mild degree, we sort of have this lurking sense that we've been through this. Why can't you get through this? Why can't you get over it? I once heard a therapist say to a depressed patient that depression is nothing but feeling sorry for yourself. And the truth is that it's not that the psychological part isn't part of depression, but it's also a physiological thing. So it's not like somebody wakes up in the morning and goes, oh, it would be great to have major depression today. It's way more complex than that, although there is some personal responsibility and so on in it. I mean, nobody wants to feel like that. Nobody wants to feel terrible. The personal choice part comes in, are you motivated to get help and to change things and so on. But it's not a choice to feel terrible. It's not a choice to feel depressed. I'm going to make the argument that depression is a real thing with a physiological cause, as real as diabetes. You know, if somebody's diabetic and they're going into insulin shock, then you don't say, oh, just get over it. Like, why can't you just pull yourself up by your own bootstraps? Like, it's a real thing, and we don't think, you know, if a diabetic needs extra sugar or they need their insulin shot or whatever, we don't, you know, criticize them for it. it's a physical disease. Of course they need these things. And yet we look at people with depression and say, why can't they just get over it? And that's not right. And what really makes this clear is these vegetative symptoms. The bodies of major depressives work differently than normal people, and even normal everyday depression people. Their bodies are working differently. When you and I are stressed out and we're upset about things, we usually have insomnia, we have a hard time getting to sleep, our mind is racing. But this actually isn't the case if you have major depression. With major depression, it's actually waking up early, so you can get to sleep, but you wake up early even though you're totally exhausted. The sleep architecture is totally disordered and is completely different than a regular person, even a regular depressed, everyday depression type of person. It looks different. If you look at the brain waves and everything, you can see a difference in how the brain is working with a major depressive versus a regular everyday depression. So the brain is sleeping differently. This is biology. You also have a change in appetite. So, you're upset, you break up with your boyfriend or your girlfriend, and you think, I'm going to go home and eat some ice cream or grab some chocolate. Or, like if my mom's stressed out, I always make her macaronis and cheese. It's a comfort food. Carbs are comfort foods. And there's a reason for this, because carbs actually decrease stress hormones in the body and release dopamine and other, serotonin, neurotransmitters that make you feel good and calm and relaxed. But in major depression, your appetite is actually decreased. So normal depression, you have an increase in appetite. Everyday depression, you have an increase in appetite. Major depression, the appetite decreases. So it's contradictory. It's not what a normal person would do. There's something seriously disordered in the chemistry of the brain, because a normal person comforts themselves in order to feel better, and major depression for some reason cuts off the body's natural desire for carbs in order to self-comfort. The other weird thing about major depression is, although they have these vegetative symptoms, they have psychomotor retardation, and they're laying on a couch for a month straight watching Dr. Phil, and they don't seem to have a slightest bit of energy. And yet if you tested all of their stress hormones, they have a super hyperactive activation of the stress response. So their body is just filled with cortisol and adrenaline and noradrenaline, or what we should call epinephrine and norepinephrine, which is the proper American scientific term for adrenaline. So these stress hormones are super elevated. Their sympathetic nervous system is overactive. So you'd think that they'd just be wiped out energetically, but the body is actually blasting through the stress response, and it's really high if you tested it in the bloodstream. There also tends to be rhythmic patterns to depression. So like seasonal affective disorder is one type of depression. Seasonal affective disorder is when the amount of light outside affects whether you are depressed or not. So the less light there is, the more likely you will be depressed. That also affects major depression, probably because you get vitamin D from sunlight. Lack of vitamin D causes depression. But it's probably more complicated than that. There's a lot of different hormones and so on that are affected. So this is biology, right? This is not just all in your head. You have the brain chemistry is different. The sleep cycles are different. You've got stress hormones and neurotransmitters and all these things in the body that are biological, physiological. It's not all in your head like so many doctors will say. These debilitating symptoms are about biology. These are bodies that are working differently. So let's talk more about the biology of this. What's going on in the brain of a major depressive? So we'll start off talking about the chemistry of it. Okay, don't panic. I know you may not be familiar with these terms. Hopefully you learned some of them in Psych 101. So you've got two brain cells, you've got two neurons, and the way they talk to each other, they're not actually touching, right? So in order for one neuron to send a message to the other, they have to have a chemical messenger that goes floating through the synaptic cleft, through the gap in between, and does something to the other neuron to activate it. And this chemical messenger is what we call a neurotransmitter. So you see in the picture, You've got your axons and dendrites, and the news travels through the neuron using electricity and then crosses the space, the synapse. And it has these little water balloons inside filled with neurotransmitters, and these are the excitation signal comes along, the electricity pushes the neurotransmitter out, they float across, and they bind to the receptor on the other side, and then all of a sudden something changes in the neuron. You'll learn that in physiology. The neurons talk to each other. And there's tons of different types of neurotransmitters, probably hundreds. But what's pertinent here in depression is just a handful of them. So the first neurotransmitter, norepinephrine, it's a big one. This first got implicated in depression in the early 1960s. And the evidence was around that time the first generation of antidepressant drugs had been developed, called Mao Inhibitors, monoamine oxidase inhibitors. Okay, so you've got your neurotransmitter release, the neuron's excited, it binds to the receptor, and then after that, the neurotransmitters have to be cleaned up. You've got all of them dumped into the synapse. So you've got two options. You can take the neurotransmitter and you can recycle it, or so you take it back in, it gets sucked back in and can be reused. Or you can trash the neurotransmitter. You can get rid of it. There's enzymes that will come in and they'll clean those, break down the neurotransmitters and get rid of them. And it goes into the cerebral spinal fluid, your bloodstream. You pee it out, you sweat it out. So it's either recycled, what we call reuptake, or it is trashed. So MAO inhibitors inhibit the enzyme that breaks down norepinephrine so that you have more of it in that synaptic cleft to activate the neurons and make you feel better. So you don't break down the norepinephrine, it's just floating around, and it doesn't have anything else to do, so it keeps hitting the receptors a second, a third time, and then suddenly your depression goes away. So your theory at this point, of course, is there isn't enough norepinephrine coming out in somebody who's depressed, so you need to get the signaling of norepinephrine to increase, add more norepinephrine to the body. So then in the late 60s, we had tricyclic antidepressants come out, and they did basically the same thing, which is they actually block the recycling pump so that norepinephrine can't be recycled back up into the sending neuron. So of course there's more norepinephrine in the synapse, the receptors keep getting activated. This is what we call the norepinephrine hypothesis. And there are many classes of drugs that will decrease norepinephrine release and of course cause depression. If you have excessive norepinephrine, you could have high blood pressure. So if you take high blood pressure medication that decreases norepinephrine, you don't have as much norepinephrine release, and that lowers people's blood pressure, but they also tend to get depression. So you take a depressed person, you find a way to boost their norepinephrine, and of course they feel better. You take a normal person, you find a way to decrease their norepinephrine, they get depressed. So there's got to be a problem here with too little norepinephrine in depression, and that of course is incredibly convincing. So at this point, you've got to say it's convincing, it's irrefutable. So another thing that happened is in the 50s, people figured out that norepinephrine, they took a certain part of the brain in a rat, and they put an electrode in where they could stimulate neurons and force neurons to talk to each other. You stimulate this pathway, and you actually can make the rat really happy. So of course the question is, how do you tell when a rat is happy? And what you do is you make it work in order to get this neuronal stimulate. It has to press a lever. They had to press a lever 25 times, and then it got a brain buzz. And they found that the rat will actually work themselves to death to get this stimulation in the norepinephrine part of the, or in that part of the brain. Better than food, better than sex. They get addicted. They go through withdrawals. This part of the brain, these neurons we knew mediated pleasure, and they called this the pleasure pathway in the 1950s. So of course you look at it, and then you have to say, do we have the same pathway? So of course people went looking for this pathway, and we did see that humans had this pathway. And in neurosurgery, You don't anesthetize the person when you work on their brain because the brain doesn't feel pain. So you numb the skin. Once you get through the skull, the person can be kept awake during surgery. And they needed to because they put a needle into your brain, and the person would, flap their arm or say a certain thing, feel a certain thing, smell something, and you'd have a roadmap of the neuron. So if the person smells, asparagus with this neuron, then you have to go 2 neurons to the right. So anyhow, they started stimulating the same part of the brain as in the rat, and they have transcripts of what the people were saying when this part of the neuron was stimulated. And they'd say, that it just felt wonderful. It was like sex. It's like getting back into the bed and having a breakfast, somebody brings in breakfast, or your husband calls you, or your mom made cookies for you, or you're sitting in front of a cozy fire. And they just have these feelings when this certain pleasure pathway in their brain was stimulated, just like in the rat. So, of course, we found out that this pathway uses norepinephrine. Not surprising. So if you've got a shortage of norepinephrine in that part of the brain, then now you have a loss of pleasure. That part of the brain is not working. So totally convincing, lots of reasons to believe in the norepinephrine hypothesis. But the problem was that norepinephrine signaling changes really fast. And you put a depressed person onto a norepinephrine drug and they don't get better fast. It takes months. So why is it that you can immediately change the level of norepinephrine and yet their depression doesn't change? So it turned out it's more complex than that, of course. We also have dopamine. Dopamine is activated when you take cocaine. And suddenly we realize that norepinephrine is not the major player in the pleasure pathway. And then in the 80s, we have Prozac, which is an SSRI, a selective serotonin reuptake inhibitor, and now serotonin also played a role. So we've got dopamine, norepinephrine, serotonin. It's much more complex than what we originally thought in the 50s and 60s. Prozac actually stops serotonin from being recycled, just like the tricyclics. So if you give somebody Prozac, they feel better. Of course, what do we think? You have too little serotonin. So now we have this idea that serotonin is the happy chemical, right? That's what we've all been taught. Serotonin makes you happy. And so now, of course, there's a huge fight between people who believed in norepinephrine was the major thing, dopamine's the major, serotonin. So in the 80s, there's just this big controversy between all of the depression psychologists and scientists and who's right. So, of course, now the truth of it is that it's probably something to do with norepinephrine, serotonin, and dopamine. It's not just one or the other, and it's probably even more complex than that. So at this point, we believe that dopamine has something to do with anhedonia, the lack of pleasure, because like if you won the lottery or you find out you got an A when you thought you had done bad, that feeling of pleasure and reward that is released in your brain it's caused by a release of dopamine, which is also, if somebody takes cocaine and they describe what it's like, they say that it's like a great feeling of reward. So an absence of dopamine would cause anhedonia. And then, of course, the absence of norepinephrine is going to decrease your energy. It's going to cause the psychomotor retardation, because epinephrine and norepinephrine, that's adrenaline. That's what gives you energy and makes you feel, ready to take on the world. So you don't have that. Now you have psychomotor retardation. And the absence of serotonin is the grief and the guilt and all those negative emotions that people are experiencing. And like I said, it's probably more complex than that. As we peel back each layer of the biology of depression, we realize that it is more and more complex. More neurotransmitters are playing a role. We've also found that people with obsessive-compulsive disorder have a serotonin deficiency. So that's some evidence of that sort of obsessive grief and obsessive guilt, excessive, beating yourself up mentally is probably because of low serotonin. So people with obsessive-compulsive disorder are often prescribed serotonin in order to help them to get over that. There's also a neurotransmitter called substance P, which you often don't hear about. The P stands for pain, and what it does is, if you hurt yourself, then you have all these neurons that, of course, release chemicals. They release substance P, and it basically tells your body that you are in pain. So if we decrease substance P signaling, like with a drug, then sometimes depression gets better. So what does that suggest? It's not just a metaphor that depression is psychic pain. You actually are in pain with depression. Your brain is using the same chemistry for your depression, the painfulness of depression, as it would be if you stubbed your toe on a table. In the 1940s, we had what was called the triune brain concept, which is very simplistic, but sort of the idea that down at the bottom, you've got the nuts and bolts part of the brain, the reptilian brain that controls breathing, body temperature, and so on. A lizard brain, lizards have that part of the brain. They don't have a more complex brain. So this is all the regulatory things. It measures your blood glucose levels, your blood pressure, sends out signals to your blood vessels to tighten them up, to keep blood moving through. On top of that, on top of the lizard part of the brain is the limbic system, and the limbic system is much more complex. It controls emotions. It controls, the amygdala is part of that. Imagination and so on is part of it. Fear and anger and sexuality and all sorts of things is part of this brain, and it's very complex. We don't know much about it at all. So all the parts of the brain talk to each other. So if you are feeling, cold, then the emotional limbic part of your brain is going to be activated, and it's going to be communicating with each other. So the triune brain concept makes it look like there are distinctly different parts of the brain, but it doesn't really work like that in actuality. So the third part of the brain on top is the cortex, and this is the logical, sort of analytical part of the brain. Humans have more cortex than any other type of animal. Primates have a lot, whales have a lot. And it's not so much how much cortex you have, but the ratio of cortex to the rest of the brain. So we have a really large cortex in ratio to the rest of the brain. So even though a blue whale has a brain size of a Volkswagen Bug, obviously their cortex is way bigger than ours, but the ratio of cortex to the other part of the brain is much smaller. So we have the biggest cortex out there, and what that's doing is it's analyzing things. It's doing your taxes for you. It's processing visual information, and tells you, how to make good decisions. It's doing sensory information and analyzing things. But there's this interesting part of the cortex that's super relevant to depression. So let's say you go outside and all of a sudden a lion attacks you. What are you going to do? So you're going to activate a stress response, fight or flight. You may feel a sense of grief because you just, lost your arm. You may hunker down and have psychomotor retardation. You're going to lose your appetite, right? Dinner is not important. Sex isn't important. Reproduction isn't important. So you have this whole stress response that this part of the brain is thinking about. It doesn't really like. So anyhow, you have this depressive response because of stress. So if you think about a soldier that's come from war, they're going to do the same exact thing. Things shut down in their body with a stress response. It's a good way to deal with stress. It's fight or flight or freeze. And that's sort of what depression is this sort of freeze response to stress. To say simply, what depression really is the cortex saying to your brain that this is as real as we've been attacked by a lion. Depression is the cortex having too many sad thoughts and getting the rest of the brain to go along with it. So the cortex is basically analyzing the situation, saying this is a horrible situation and we need to have the fight or flight response. And of course, if you can't get away from it, now you go into chronic stress, which is sort of that freeze. So depression is a is a severe chronic stress. And it's the cortex is looking at things in life like a divorce and saying this is as dangerous for us as if a lion had just attacked us. And we need to have the same physiological response to it, which is this extreme release of hormones and chemicals. And of course, the problem is it's chronic. It doesn't go away. And all of these intensive chemicals being constantly released over an extended period of time is going to totally recalibrate the system. And that's how you get that body chemistry disequilibration. Is that some word like that? But anyhow, you're an imbalance. You get a chemical imbalance in the brain. And it's the cortex saying this is how we should view the world and convincing the limbic and the inner reptilian part of the brain to go along with this. So if that's how you think about depression, which is very simplistic, if you look at treatment for depression, you could, in theory, you could cut right through the brain, separating the cortex from the rest of the brain, and then you should be right. And that actually is a medical procedure that can be done. It's called a cingulotomy, and you cut part of the cortex off, the anterior cingulate, or the cingulum bundle. You sever that pathway, and people actually get a lot less depressed at that point. So it really can work. Now, it's severe. You wouldn't want, you really don't want that to happen because you're stopping communication in the brain. But if you have severe enough depression, it may actually be a method. It is a method that some people believe is worth trying. Then this would be someone where like every type of medication, even electroconvulsive shock therapy doesn't work. Usually it's somebody who's tried to commit suicide multiple times, and the doctors and psychologists believe that the person is going to try to commit suicide again, and nothing else is going to work. So you've tried everything, every combination, and it's just not doing anything. They're still back in the hospital. They're still committing suicide, and so people will try this. And the amazing thing is that it actually does work. It actually does decrease depression. So what happens to these people when you do a cingulotomy? And let me point out, this is not a lobotomy. That is the frontal cortex part of the brain that controls personality, and that gets scrambled. And that it basically stops personality, and the person becomes much calmer, and sometimes almost vegetative. Cingulotomy is totally different. And so when you have a cingulotomy and your cortex has been disconnected from the rest of the brain, the cortex's job is to come up with abstract, sad thoughts, get the rest of the brain to go with it for depression. Also comes up with pleasurable thoughts and gets the rest of the brain to go along with it. So you've also just wiped out the person's ability to really enjoy life and to have pleasure. And that is something that we see with a cingulotomy, which is a horrible thing. So pain and pleasure really do go together in a certain way. But, if you've got somebody who's on the point of committing suicide and is going to be successful, they're not feeling pleasure anyways, and it may be worth it for them to have a cingulotomy. And some people really do choose to do this. It's rare, but it does. It does happen.